Good morning, friends. ECME is really a wonderful, unique concept. I must congratulate here Team IMA for conceiving this wonderful idea and implementing it successfully over the past few months. I also should thank executive team of IMA for making me a part of this ECME and inviting me here for addressing on this platform. My 30 years of journey with hernia. I understand hernia is a hardcore surgical subject, but looking to its prevalence in society and the kind of changes, advances and innovative things that hernia has seen over past 20-30 years, I thought it will be worth addressing to this academic crowd of IMA Anand on this platform of ECME. I'll be limiting myself only to inguinal hernias, and today my focus would be non-surgical branches of IMA. I am witness to this evolution and revolution in the field of hernia. Way back in 70s, we learnt anatomy from skin to sac, from outside to inside. Today in the era of laparoscopy, we are learning and practicing anatomy from inside to outside. When it was first time introduced, the laparoscopic anatomy of inguinal hernia, it was amazing to see an entirely new world. I understand there are separate chapters on laparoscopic anatomy of inguinal hernia. Diagnosis earlier used to be exclusively clinical. Today, ultrasound and CT scan can pick up inguinal hernias far before the surgeon's finger can palpate the hernia. The major change is in the field of surgery. Now we have started doing posterior repair. We have shifted from anterior repair to posterior repair. About this, I'll be addressing a while later. Technology, as in any other fields, has remarkably changed. Optics, energy sources, mesh processes and fixing devices has given us a very sturdy and a strong surgical repair of inguinal hernia. Above all this, awareness of patients because of Google and expectation of the patient because of the legal situations has tremendously changed in the last 30 years. Is treatment always surgical? Unfortunately, the answer is yes. In majority of cases, we do operate for symptoms or for fear of potential dangers or for existing complications. But small, asymptomatic, reducible, direct hernia in elderly can be observed. Though there is a small subgroup of patients who may be observed and may not require, and we don't offer surgery to them. For years, hernia was repaired by suturing its two edges, namely conjoint tendon and inguinal ligament. But that did not last long due to unnatural pressure over the suture line, ending up with recurrence rate to the tune of about 20 to 30%. So surgeons added mesh to bridge the defect and make the repair tension-free. Posterior repair is another novel concept. On the principles of Pascal's law, it was thought that by placing a mesh behind the defect is always more effective and long-lasting instead of deploying it in front of the defect as an onlay mesh. Stopper over the drainage pipe of the bathtub explains it well. If the stopper applied inside the bathtub behind the hole is more sturdier than the one it is applied outside the bathtub. With mounting pressure in the bathtub, inner stopper will be more secure and the outer one will fly away. So, posterior repair may be in the open surgery or in the laparoscopic surgery is always considered more secure. Intentions of treating hernia are listed here. But of all, avoiding recurrence is the most important intention for all the surgeons. If you look at it carefully, majority of inventions and alternatives offered by researchers in the field of hernia surgery are intending towards avoiding recurrence, meaning thereby even today recurrence is the major concern for hernia repair. Restoring anatomy, preventive operative complications, giving minimum postoperative pain, allowing the patients to early return to work and to do the surgery at the minimum cost are the otherwise basic intentions of operating hernia surgery. 70s was the era of basinage repair, wherein conjoint tendon and inguinal ligament were simply sutured using non-absorbable suture material. But somehow, because of the tension created, an unnatural tension given to the repair, it never lasted long. So it's now almost out of fashion, and basinage repair is almost a history now. In 80s, we saw two important innovations. Liechtenstein's repair, hernia mesh plasty. This was the most popular, and even today it is most popular. Bridging the defect using a mesh proved to be more successful with minimum recurrence rate, and even today it is practiced extensively. Shoulder repair is a very exclusive kind of repair, practiced more so in Toronto. Shoulder clinic exists in Toronto, Canada, wherein without using a mesh, using the own body tissues, suturing it over and over in say 4 layers, we can give a sturdy posterior wall of the inguinal canal, and the recurrence rate can be avoided. Though it's an excellent method of repair, it's not very much accepted by the surgeons because technically it is slightly more difficult. In 90s, we entered the era of laparoscopic surgery. Almost all fields of general surgery accepted the laparoscopy, and hernia was no exclusion. Basically, we have two types of laparoscopic repair. TEP, totally extraperitoneal repair, wherein we enter the retropubic space without entering the peritoneum, create a big space behind the pubic bone, dissect it out, reduce the sac, and put a wide, large mesh in this particular area. I can demonstrate it on the schematic side on one side and the live surgery on the opposite side. This is today one of the most practiced surgery and most accepted surgery as a laparoscopic repair of hernia. Another type of laparoscopic repair is TAPP, transabdominal preperitoneal repair. Here, the space explored, the kind of dissection, reduction of the sac is all same, except for we enter that space of radius through the peritoneal cavity, and so there is a little technical difference between TEP and TAPP. Details of these two surgeries are out of the place for this particular CME, so I am not discussing it further. Why laparoscopic repair is becoming more and more popular day by day among surgeons and patients? Many reasons. Basically, it's a posterior repair, so more sturdy, more long lasting, minimum recurrence rate, less pain, less analgesics, less bleeding, shorter stay, cosmetically superior, minimum chances of wound infection. Right and left, both the sides can be addressed together from the same 3 keyholes. Femoral hernia, if at all they are there, can be addressed simultaneously. To conclude, laparoscopic repair may be TEP or TAPP. It is best suited for bilateral hernias and recurrent hernias after open repair. So this is how the laparoscopic surgery is evolving and gradually becoming standard of care. The other side of laparoscopic repair, the flip side, it has an extremely long learning curve. It's not very easy to learn inguinal hernia compared to many other laparoscopic surgeries. Firstly, because it is entirely new anatomy, surgeon takes a little longer time to understand it. Hand-eye coordination is slightly more difficult. And thirdly, we are working in a very limited space as long as the hernia is concerned. For all these reasons, it takes longer time for a general surgeon to learn inguinal hernia repair by laparoscopically. And this is one of the most important hindrances in making this surgery popular among surgeons. Otherwise, general anesthesia is mandatory. It takes a little longer time. It's not feasible if previous surgery is done in that area. Complicated hernias, we cannot offer laparoscopic surgery. Injury to gut and major vessel is a concern for many surgeons because in an open surgery, we never come across such vital structures. And laparoscopy, we are potentially creating a danger of injuring such vital organs. And it is expensive also. All said and done, the conclusions can be drawn like this. Open, tension-free mesh repair is still considered a gold standard for unilateral hernias, that is, Liechtenstein's repair and its modifications. Laparoscopic hernia repair is a gold standard only for bilateral inguinal hernias as reported by many leading surgical teams. Robot-assisted repair of groin hernias is rapidly developing. It's another fad. It has its own advantages. It has better visualization, wristed movements are good, ergonomics are good, but still it is not widely practiced. It takes a little longer duration, far more longer duration than open and laparoscopic repair, and it is way too expensive as on date. Only time will tell how robotics for hernia repair will be accepted by surgeons and patients. Before I conclude, I would like to put a small debate to this audience. Is an R&D race driving the surgical market? Mesh and device industry is growing very fast, and it is almost going to touch $6 billion by the end of 2020. Is industry a driving force? Is industry influencing the decision making in hernia surgery? Not only in hernia surgery, in many of the surgical and medical aspects, industry is becoming an important decision making force. I am leaving this question for people of IMA Anand to discuss and answer.